Agenda item number 7, update on the survey of public and private shelters and discussion of minimum standards protocols for shelter medicine.
So after all the wonderful presentations this morning that demonstrated that the MDC is moving forward, I hate to disappoint this afternoon and say that don't have much to go on, but this has turned out to be a little more difficult than first envisioned, and we are making progress, but there's just not enough to report really. So before you is a summary of the questions that Dave and I thought would, at least in the beginning, be appropriate to ask of all the public and private shelters. And so we have been accumulating some of the data, certainly from the premise permit holders, but State Humane has had a little difficulty in finding the time in the short term to get these surveys out there, but I'm assured that they'll be able to turn that around. I just have one question of anybody here or in the audience. If anybody knows anybody who works for the CDC and has some leverage there with their IT department, I'd appreciate it. I put together this survey in an application, an open source application from the CDC called EpiInfo. There's a module in EpiInfo that allows data input into the questionnaire from remote sites. So you're supposed to download software from the CDC, put it on your server, and it allows then access through a back door for the data to get input, except that RCIT, Riverside County IT, can't seem to get the cooperation of the CDC to make it work. Every time we call up, they tell us to do something different, and when we say we did that, they say, well, now try this and now try that. So I hope that we don't have to get these things scanned and faxed over to us or emailed to us and then have my staff have to input it, but that may be the case. But nevertheless, we'll persevere. Right, Dave?
That's correct.
We can talk offline, but have you considered doing SurveyMonkey so that you just create an online survey through SurveyMonkey? It won't tabulate the data for you.
That's what the EpiInfo does, yeah. You can run all kinds of...
I mean, I think you can, yeah, we'll talk. I think you can have SurveyMonkey do some tabulation. It's probably not as sophisticated as what the CDC will do through their application, but it'll prevent your staff from having to actually hand count the data. So we'll talk to our IT folks and see.
Questions?
Why are you laughing?
You're really funny. No reason.
You're laughing at me, not with me.
You're wrong about that.
Questions from the audience, comments? All right, so we had set a very ambitious timeline on this and hope to have this survey now, but we realized that the survey went out and just about getting back in and getting things tabulated. We are having the meeting in October, and so we can expect to see this information by then, and we'll start to process it. And it kind of fits with what we're going to be talking about in October in terms of shelter medicine anyway, so it'll all fit together well.
I appreciate you making excuses for me.
I think that's what a good chair is supposed to do. Yeah. All right, we're going to move on to item number 9, and then again we'll come back to item 8 in a minute. Item number 9, extended duties RVTs.
Well, notice where we are with our report here. Well, Dave and I actually had a couple of discussions, and I interviewed and discussed and solicited input from our local technician association, as well as several shelter veterinarians and regulatory agencies. And what we found is that we were duplicating the process of the premises task force. So Dave and I felt that it would be best at this point to not duplicate work, and instead, with each item that comes up, we need to ask the question, where do RVTs fall in this discussion? Because I don't feel, and Dave can clarify as well, there are no extended duties at this point in time that need to be done by RVTs that will benefit the consumer. The only things that we find are in the shelter area. And I feel like we're already working on those.
I'll add on to that. I thought this topic would be a lot simpler from the very beginning. I thought people would just flock to us and say, hey, look at this, look at this, look at this, here's an idea, and we'd have a list of 100 different tasks we could debate back and forth forever about whether it was appropriate for an RVT to perform that function or not. And that has not really happened. And I think part of it is the fact that we laid down the criteria that this is an access to service issue, not an enhancement to the profession and job security. But with that said, I think this placeholder should always be there on the agenda, either physically as an agenda item or always in the back of everyone's mind, because as Christy has just said, this goes across every issue that's discussed by the committee and by the board. And yes, there's probably the greatest potential to define some very specific liberal types of tasks in shelter medicine, but there's also the discussion coming up of rehabilitation and physical therapy. So what is going to be the RVT's role in that issue? Those of you that were at the Senate hearing and the sunset, rodeos, is there a potential role and the public good served by having RVT's roles defined in a rodeo type of a situation? I brought up earlier the discussion, the point of premise permits, and could an RVT play a role in the premise permit situation? So you can look at almost any topic that's going to come before the committee, and I think we have to fall back and say, okay, let's always make sure we're looking at what the RVT's role is in that. Could they play an expanded role that would benefit the public by that service that is offered? And so we can either keep it as a separate agenda item, or I'll just remind you every single time we talk about a topic.
Well, I mean, that's why we're a multidisciplinary
Right.
committee.
And then the other hope was that we do have members of associations here in the audience, and this is an opportunity for them to come forth and discuss this issue in front of the committee in an open forum.
Any other comments? Yes, Jennifer?
I like the idea that Dave and Christy came up with. I think the topic alone, it was ambitious to try to recreate the wheel. It's starting from scratch on, it's just too broad of a topic, so I really like that we just kind of included on everything else we're doing and see where RVTs stand on each issue. Good job, guys.
Two comments, one semi-political and the other one just to update, but extended duty in and of itself is typically not something that you see on a public protection board. It's not our role to extend anyone's duties, whether it be veterinarians, RVTs, any professional group or a regulatory agency. Our mandate is consumer protection. So extended duty in and of itself raises alarms for me. What's our role in responding to extended duties? That is a function, but creating them is not. So I think that this serves two purposes. One, it addresses the issue of, is there an access problem that we have an obligation to address, and if there is, what is it, and let's define it separate and apart from just an extended duty. Secondly, it highlights that even though an issue doesn't say RVT issue, that it's embedded in everything we discuss, including drug compounding, which is going to be discussed later today. And that was one of the topics brought up at the Sunset Review Committee hearing, was that, you know, the MDC was very heavily weighted on veterinarian issues, and we're not responding to those RVT issues that have been longstanding issues. And I think it's a fair point to make that Dave just highlighted. This isn't separate and apart from anything else we do. RVTs are in every single one of these issues that we've been discussing and play an important role. Now, if we need to step back and say, how does this affect RVT scope of practice, from the standpoint of, is the education and training keeping pace with how we're folding them into some of these other areas, that's a different discussion. But extended duties in and of itself, and I voiced this concern during strategic planning, I voiced it with the chair, and I voiced it with Dave. That isn't our role. So I think this is a really important point to make during this discussion, and we can move forward however the committee sees fit. But I think having it on the agenda as an extended function or extended duty function is ill-advised.
Christie?
That is part of what we discussed, because I feel that it does not matter what we discuss up here. When we talk about the veterinary profession and we talk about the consumer protection aspect, we are talking about RVTs. That's why we're on this committee, that's why we're on the Veterinary Medical Board. And so I think it's extremely important to know that whether we directly or indirectly state RVTs, we're always including RVTs. It doesn't need to be stated RVTs. We're on here, we're on the VMB because we have a vote and we have a voice. And so I don't think that just because we state every single issue, well, where do RVTs fall? It doesn't mean we're not considering RVTs because we're obviously here and we're speaking in that role. So that's exactly what we were saying. There are some issues like compounding and like animal rehabilitation that there will be bigger roles that we need to discuss. But there are times that we're talking about the profession. It doesn't matter whether it's the veterinarian or the RVT, it's the profession.
Any other statements from the committee? We've asked the professional organizations that represent RVTs if they, at the last meeting, said this is going to be on the agenda. So if you have anything that you would like to add to the conversation, this would be a good time to do it.
Unfortunately, our board has not met since the last meeting, and we'll be meeting on Friday. So I'm not prepared to bring you a list of recommendations from our board at this point, although I'm a little surprised to hear Christie say that there are no extended duties that would benefit the consumer except in a shelter environment. I could probably come up with a whole list of things that might benefit the consumer, but I'm not going to list them today. The one issue that you did bring up about RVTs at rodeos, I believe that is now on your strategic plan. It's something that you're supposed to be dealing with. And since this was an issue that was potentially to be included in the sunset legislation or the sunrise legislation, the fact that has not been discussed is kind of a handicap. If this committee could come up with a recommendation about RVTs at rodeos, it has the potential to get into 1193. But apparently no one is interested in discussing it since there's no extended duties that would benefit the consumer. And I also don't understand Anne Marie's position that it's not the job of the Veterinary Medical Board to discuss extended duties. It specifically says in the Practice Act that it's the job of the Veterinary Medical Board to define the duties of an RVT. So if it's not the job of the Veterinary Medical Board, then whose job is it?
Is that a question or
Yeah,
is it anecdote?
that's a question.
Okay, so our job is to define the duties as they currently exist in practice. So our job is to not expand the profession or expand the scope of practice of RVTs. It's to define those duties that are currently in the practice. So those duties that you're currently trained to do in your educational environment, those duties that are currently defined as duties that can be delegated to an RVT. Our job is to respond to the statute and define those duties. Our job is never to expand the scope of practice of either profession. And that's not just unique to the Veterinary Medical Board, that's all healthcare practitioners and all governing boards. Kurt can speak to it as well. So that's not the Veterinary Medical Board's job. We're not here to represent the interest of the profession. We're here to represent the interest of the consumer. And so our job would never be to expand scope of practice.
Even if the scope of expanding the scope of practice would benefit the consumer?
If there's an access issue or there is a need and a demand for services that are going unmet, and that need or demand is creating a risk to the public, then the board may be on the leading edge of something. but it's only because we're responding to something that's happening in the profession or in the population where the public is placed at risk. So the board has to do something to respond to that, but not in the interest of expanding the profession.
Well, does this committee have any intention to discuss an RVT at the rodeo?
We do. It's actually on our agenda at the next meeting. I mean, there was no point in putting it on this agenda because this agenda was full. That was assigned to us by the Vet Med Board at the last meeting. We already had a full slate, but it is going to be discussed at the next meeting.
Of course, by then, the legislation will be done with.
Well, our process is to do it once and do it right if we can. And so it's also, we knew that we had the shelter community coming to the October meeting. And we saw the opportunity there to have the shelter folks and the rodeo folks interface. And instead of having some kind of serial meeting, trying to get it all done at once as far as rodeos go. So there was a method to the madness here.
Although I don't really see a relationship between rodeos and shelters, but.
Well, I think that we're looking at RVTs. Okay, I get you with that. But the reality is that when we talk about the shelter issue, in many ways it's wrapped up into an RVT issue. Do you see that?
Well, I just heard that RVTs are involved in everything that you're doing, so I don't see that what you just said doesn't really make sense.
So to answer your question, we will be discussing rodeos in October.
Okay.
Yes, Jennifer?
I just have a general question that maybe you can answer. I completely see where Anne Marie is coming from with the job of the board is to protect the consumer, and the job of the public interest groups is to protect or to advance the profession. Where does the care and protection of animals fall in that generalization?
Our consumer includes the animal. So our consumer is the animal patient along with the client. So we have both, we protect both the client, that being the individual that's agreeing to the services and paying for those services rendered, and the animal patient.
Okay, because my concern, obviously, I've been in shelter medicine for the past decade, and there is a demand and need for service that is going unmet, and RVTs and shelter medicine are hindered by certain restrictions in the Practice Act. So that was what prompted me to recommend extended duties for RVTs as one of the priorities several VMB meetings ago. So I would hate to see it completely be dropped. I think changing it to kind of piggyback it onto the shelter medicine minimum standards would be good, but I would hate to see it completely just be dropped from priority.
I don't think anybody is saying drop it. It's addressing it as issues come up and addressing it as, and this is why I was shocked to hear you say that we can't address something with rodeos. We can't just say randomly, oh, let's bring up rodeos, when we haven't even been assigned rodeos.
You
So-
can bring it up because it was part of the sunset discussion.
Right,
It was,
and when
and
rodeos-
you brought up all these other things that were part of sunset, and it's going to be on the agenda. It's just the question of timing of the.
And when rodeos come to our agenda, we will address RVT issues and rodeos, and just like we were reinventing the wheel when we were talking about things that were coming up. It was talking about issues that were being already addressed for shelter medicine and how it impacted RVTs. And so that's why we felt that it really does, there is nothing else that we can do but constantly talk about how does an RVT fit into this in each issue. So when animal rehab gets to the table, or whatever name we end up with gets back to the table, it'll be the same thing. You know, when we talk about compounding, where do RVTs fall?
Other comments? Val's?
I'll be quick. Just from the CVMA's perspective, we have over 900 RVT members, and the CVMA was very instrumental in all of you sitting here because the MDAC was very much something we thought was very important to have a comprehensive group of professionals looking at the profession as a team rather than a lot of the divisiveness that went on in the past when it felt like things were more separate. And so I appreciate the comments that every issue that comes up really needs to be looked at from a team perspective, both veterinarians and RVTs, veterinary assistants, their role as well. I realize they're not licensees, but the practice is a team, so everybody's important. And I think that it's from my perspective, it's really great to see this group doing what it should be doing and not looking at things, as individually as they used to be. Leah Schufelt is our RVT representative from our RVT committee, and on behalf of the CVMA, she's now coming to every VMB and MDC meeting, and she's been doing some behind-the-scenes work, so I'm going to turn it over to her.
So I was going to say the same thing. I actually was talking to Dr. Pollard on the airplane this morning about that exact same thing that Dave said, as far as all of these issues affect RVTs as well. And so in the Sunset Review tape, when I watched that, I was surprised to see the same thing, that it was discussed that RVT issues were not being discussed, because I feel quite to the contrary, that every time an issue is discussed, the RVT aspect has been addressed as well. And I think what you guys have just talked about is a great idea. So kudos to that. And then when we have reached out to our membership as far as extended duties, we got, me personally at least, not much of a response. So I guess when I talked to Dr. Klingberg, that does speak some things, I suppose. So perhaps not that we, not necessarily a great need out there for that, except I do believe in the shelter community for sure that there is. So other than that, especially on the, side of consumer protection and all of that, because we did also mention, I know when I spoke to people about it, both via email and personally, I said not from a, career advancement part, but as far as things that are actually in need. And I was not met with great response for anything that people could come up with. So I think that that's something that, speaks to that. And I know on our RVT committee right now for CVMA, we have a lab shelter position, and it's filled by somebody in laboratory medicine. So perhaps that's why we don't have greater response from that. But so yeah, kind of exactly what Val said, but I think we're on the right track. What you guys have said, I would second that. So thank you.
Hi, my name is Cindy Savely. I'm an RVT, and I'm a member of the Sacramento Valley Vet Tech Association, and I'm on their board. Last Thursday, we had a board meeting, and this question was asked, and there were 3 things mentioned. RVTs giving rabies vaccinations/vaccinations, parasite control, and wound debridement. So I told the board I would relay the information. Okay, thank you.
Are these in a shelter setting or in any setting?
It was, it started out as in a shelter situation, but as the conversation went, it went beyond that. But basically, it was discussing shelter environment.
When I spoke to that board, and I got the feedback from your board.
Oh, you got it?
Yeah,
Okay.
I did, and those
Okay.
things, they told me it was for a shelter environment.
Okay.
When I spoke to them, it was
Yeah.
for a shelter environment.
Okay,
So I want to be clear, is this for a shelter environment or not?
a shelter environment.
Okay.
Although there was discussion and interest in RVT duties being expanded in other areas than just the shelter. But the 3 things I just mentioned were in a shelter environment.
Thank you.
Is that okay? Yeah,
Great.
okay.
Other comments from the public? I recognize that we've got all of these different discussions going on and why we're not trying to duplicate work. But I'm also sympathetic that CARTA's board is not met. And we did want to hear from the professional representatives about this extended duties issue. So we're going to keep this on the agenda for next meeting. And I hope to hear from CARTA's board or the representative regarding this issue at that point. At that stage, I will make a decision as chair whether or not it will continue to live on the agenda or it's just implicit in what we do, which has already been stated.
Can I ask how often CARTA's board meets?
Every 2 months.
Okay. So we will have, yes, we can't hear you, so yeah.
Well, and just like I was speaking for the Sacramento Valley Vet Tech Association, are there any plans to contact any of the other local associations, or has that been done?
It's not been done. I mean, I guess honestly, we look towards the professional associations to do some of this outreach for us.
Okay.
We look for things like these videos to do some of that as well. Also, the agendas are part of the public record.
Okay.
They're published online prior to the meeting. So we feel that for those who are engaged, there are opportunities to educate themselves about what's coming up.
Okay, well, then maybe I'll try to reach out to some of the small associations and get them engaged.
That'd be great.
Thanks.
Kurt?
Thank you, Mr. Chairman. Just so I understand, notwithstanding the October meeting and carved reporting, it's my understanding, I'm just trying to synthesize this, that the feeling on the board, on this committee, is that the practice of RVT is so interwoven in everything that happens here that there's really no need to set it off by a specific agenda item. Is that kind of the consensus?
Well, I think, go ahead.
I would disagree. I think from a transparency perspective, this body needs to be as open as it can be relative to all the stakeholders. And the VMB should be the same. So, other than a decision made at the next meeting about how to go forward, I would suggest that we keep it like this because it then is obvious which direction we're going.
Well, again, I have no stake. I was just trying to synthesize sort of what was going on. So that's at the will of the committee.
So, committee, I mean, one of the issues here is we're stumbling over the phrase extended duty. I mean, it's one thing to have RVT issues, and the reason why it's important to keep something going on the agenda is because the public can't speak to it, they can't communicate with us unless we have something on the agenda, which is why I was going to say.
My understanding is that we were going to constantly, I actually was going to bring this up, we were going to constantly have something on the, it was going to be on the VMB agenda and on the MDC agenda referencing RVT issues. Not necessarily extended duties, but somehow in order to be able to discuss RVT concerns, it was going to be on the agenda.
Okay, so clarity, an RVT standing report is on the VMB.
Okay.
The MDC does not independently set agenda items. They're delegated by the VMB. So that's the opportunity for the VMB to delegate to the MDC RVT issues. So the RVT standing report was never intended to be on the MDC. The MDC's issues are delegated from the VMB. And that's another issue that was brought up behind the scenes in Sunset Review, is the MDC is not autonomous in terms of setting agendas and setting issues. They are priorities that are communicated by the VMB. So
Yes, and I thought that I read that actually in our minutes, that it was going to be, I would have to look at that, but I thought that I read that it was in the minutes that we were going to have, and I know what you're saying and I understand what you're saying, but I did believe that I read in the minutes that it was going to be something that was constantly on the MDC agenda.
I'll check, but I don't think it's on.
David?
Since this is my original topic I brought up, my suggestion would be that for the present, we leave it as extended duties, but at tomorrow's meeting or the next meeting, when you're making your report, we should ask for direction from the board as to, should we come up with a better name that is more inclusive as a topic to leave on as a standing report? Do we want to follow their suit and have it as a standing topic of our RVT issues so that the public does have an opportunity to come forth at any time and just get the feedback of where they would like us to go with this?
I'll ask Dr. Nunes to speak to that, but half the room has to leave when he does that. So we will talk about it and I'll get back to you guys. Sound good? Any other comments from the committee, from the audience? All right, thank you. Moving on to item number 8 now, and that is the review and discussion of the veterinary student exemption. This is something that Diana and I have been working on. We had a lot of conversation at the last meeting. And you also have a memo here from, you've got a couple of things. You've got a memo here from legal counsel Kurt Hepler that I'm going to have him speak to. And there is also new language that's been handed out to you, sitting in front of you, as a suggestion to try and deal with some of this. Without further ado, I'd like to have Kurt chat about his little memo, and we'll go from there.
Again, thank you, Dr. Klingborg. So, as members will recall, and the members of the recall, there was significant discussion at the board level about the so-called university exemption. And I think that kind of facilitated another look at the subsequent section A5 regarding students and what they can or can't do. And there was essentially two prongs here. Number one was what can they do, and number two, if they're in a model, a distributed model of instruction, what was the expectation, what was the concern, what was the link between whatever was going along at their off-site, remote site, vis-a-vis their education. So my suggestion, although it really is sort of, like we just talked about, sort of implicit, was that the committee has some work to do, and I think that the work is sort of fleshed out in the language you see presented to you. Number one is, do you want to establish some sort of link between the actual physical premises where the student is doing whatever they're supposed to be doing, a link that sets the expectation of both parties, the supervisor, the student, and perhaps the third party, the board. And then while they're at that site, if they have a significant, if they're third or fourth year, or they have some significant amount of training, or what have you, should they be able to participate in surgery? So that was kind of the statutory issues that I confronted. The last part of the memo, page 3, talks about there's another significant concern at the committee level about section 2020-17 and the junior or senior STEM, or the graduate of a recognized college acting like, that's probably a little parlance, or acting like an RVT. And so there was talk among the committee that there was some consumer protection concerns that may be invoked, because wasn't quite sure that how long this could, something going on in perpetuity, somebody could have graduated some years ago and still be functioning in an RVT without an understanding of competency. And number two, my presumption is the board fingerprints RVT apps, and so this person would be acting like an RVT without duly licensed, meaning that we never got an application from them, we never compared their criminal history, never got their prints. So that was my concern. There's a whole lot of public policy issues that surround this thing, but I just wanted to kind of capture the legal structures, if you will. So.
Yeah. Thank you. Question I had, or I guess probably one of the issues I have with this, is the statement of clearly there is no authority for a student to perform surgery at an off-campus site. This is at least my exposure to a fourth legal counsel, and we have had multiple different opinions on this. And while I'm always nervous anytime I take exception with an attorney, I do think that our discussion when we went through minimum standards, this was brought up, and the term treatment can be referred to as surgery. That was a comment I made at the last meeting, and it's in the minutes of the last meeting. And if I go back to the definition, or in the Practice Acts, 4826, Practice of Veterinary Medicine, Surgery, and Dentistry, under C, they talk about administers a drug, medicine, appliance, application, or treatment of whatever nature or for the prevention, cure, relief of a wound, fracture, bodily injury, so on and so forth. The word surgery is not even in there. And they're talking about treatment of a fracture. and treatment of a fracture can be anything from an external device to surgery. So I would also come back to say that there was authority to perform surgery at an off-campus site under the term treatment. This has been done. The opinion of our, not our immediate legal counsel, but the one prior to that, when we discussed this at length, we were told that that was clearly covered, not only in this section that I read, which is the definition of the practice of veterinary medicine, but that when we had these students at our site, that would be included in the statement as it is. So, you know, I'd hate to think that we're out there right now and we've got a bunch of students from both Davis and Western that is doing something that is outside the realm of the Practice Act. So I would just like legal to consider, as I pointed out, 4826C with regard to the definition of veterinary medicine and the fact that treatment of these areas can be considered, or surgery may be considered as part of that.
Okay, so I find myself in a difficult position here. I think, respectfully, I think that statement is in the next memo.
That's fine.
It's not Kurt's.
Oh, okay.
So
I'll defend it if you want.
no, that's okay. I'll certainly give that. I'm sorry. So that's the difficult position I just found myself in. But now, yeah, now the cat's now we use probably a bad analogy. The cat's out of the bag. So I did, like I said, I didn't, and I don't mean to jettison that. My concern is that I only wanted to frame the conversation. My understanding was that there was significant discussion, not on the authority, but just kind of essentially having the board or the committee wrap their hands around what was going on out there. So your point's well taken. I feel a little bit awkward because I'll have to turn it over one seat down to sort of defend that. So I apologize for passing the buck.
Well, I had my hand up because I knew what Dr. Grant was referring to. First of all, you see 4826D Delta talks about a surgical. Oh, sorry about that. 4826D Delta talks about a surgical operation. So even though it's not in C, it's in D. Secondly, as the public member, I don't see any reason to be opaque in definitions. I think it's a strain for a reader, even a veterinarian, to translate treatment and diagnosis into surgery. If you want to say surgery, say surgery. I defer to the veterinarians in regard to practice. I'm just a wordsmith. And if it can be inserted where you want it to be inserted, do so.
I would agree, and part of the problem is this, is that we keep working with this document, and some of this stuff, 20, 30, 40 years old. And honestly, probably part of what should happen is the whole section should be exploded and start over from fresh, and be very simple and clear with what we write.
May I interrupt you? Let me refer you to the back page of my memo. And I've got a recommendation there where I say, here is a proposed framework, COLA. And the places that I have left blank are the places you health professionals are free to fill in.
Yeah, and I think, again, being very clear with what we're saying, do I think in whichever that we accept to put in here, surgery should be clearly stated? I absolutely agree with that. I hate to be too prescriptive, because if we miss something, then they're gonna come back and say, well, how come you didn't have that, and you list 6 other things. But, you know, I do think that some of this does need to be clear with what we're saying that these students can do. Let me ask one other thing here. On what you wrote on that back page,
Yes.
how does that relate to this, which was handed out?
Well, as noted earlier in this meeting, I don't stick to the, stick to the 4 corners of my assignment. So I branch out. I just can't help myself. That's that.
I will say one thing, Diana, this is why I wanted you on the school board. And that's why I called you that day.
Right, that's right.
So Bill,
I don't have an answer.
you've got language in front of you that is a distillation of the conversation that we had at the last meeting. Yeah, that language is the conversation that we had at the last meeting. The information that we got from Dean John Pasco, who we're going to have come up and talk to us in a couple of minutes, and then the AVMA's COE accreditation policies and procedures, which is also in the packet, and the things that off-campus sites must provide in order to be in compliance with the AVMA accreditation. So this language here that is offered as 4838.5 is the serving suggestion to try and bridge this gap and bring this into the modern era. I'd like to have Dean Pasco come up, if you will, and give us your input on this. You've had a little bit of chance to study this, I believe.
A little.
Okay.
So one of the things, I really appreciate the analysis both from Diana's document and then Kurt's more recent one. And I guess typical of those things, and much like we heard this morning, it all comes down to the words and what they mean, right? So it caused a whole bunch more questions for me for something that originally we had promulgated as something to try and solve a problem we were dealing with. And when John handed me this language this morning, one of the other things that occurred to me, and it's sort of apropos of your comment, Bill, is that at one level, not having opaque language, but also having very simple language. And so at the last meeting, I was focused on the 3rd and 4th year thing, but as I thought about it some more today, as curriculum's evolving, we're locking ourselves into something. And so I think perhaps not having it be specific to a year, but as is stated further on, as part of the formal curriculum, and then the student must have training in these activities, I think covers that without the necessity to spell out 3rd or 4th year. The language in the second paragraph, I'm still trying to get my head around. So one of the things that I had just suggested informally to the chair is that I think we're moving in the right direction. I think there's a lot of good discussion and a lot of good questions that have come up, and I think there are more that probably need to be answered. And perhaps a way to move this forward would be if the committee and the board ultimately would be open to perhaps a small task force with appropriate representatives to really take the village approach to this, thrash this thing out, and then come back with some language that meets, I think, a tripartite objective that everybody has, which is that the educational institutions are graduating entry-level veterinarians that are competent. We're getting optimal patient care in a setting where students are actively involved in learning, and that the consumer is protected at the same time. So my thought, my recommendation, if I can be so presumptive, would be to suggest that rather than spend a lot of time trying to wordsmith this afternoon, given that you've got some other big items, that perhaps a representative, I mean, you guys can think about the composition of this, but I'd certainly be willing to participate from the UC perspective. I think we could enlist somebody from Weston and then somebody from, some persons from the MDC and where the legal counsel is part of that discussion, so that we perhaps in an efficient way come up with some language that meets all the needs. So that's my thoughts.
Comments?
Thank you, Doctor. So in the law school world, the first year is always torts, crimes, and contracts. The third and fourth year language, and you mentioned curriculum was evolving, is there such standardization that if in the world you said third and fourth year, that would automatically everybody know what you meant? Because as a lawyer, that would be a concern to me, is that if curriculum's evolving, like when I was at the medical board, that the distinction between years sort of is blurry now, because there's certain places that are offering 3, certain places that are offering 6 directly out of baccalaureate degree. So, and then I would say I'd love to be part of your task force, but you threw me with the word efficient. So.
So I think, just to respond to that, there's different entities that have a voice in this, right, at one level, and that is that currently in the COE's standards for accreditation, it has to be a minimum of 4 years of training for a veterinary degree. That could change somewhere in the future. I was thinking about it more in the context that as most curricula in the U.S. and the 30-odd veterinary schools that are accredited, moving students from the first and the second year are getting more opportunity for clinical exposure at those levels. And so I didn't want to be, I'd prefer language now that I thought about this a little bit more that didn't specify years, but tied it to, which I think most reasonable people would agree to, that if the educational institution has provided the foundational training that then lets them apply that training, then that would be the appropriate entry point to do those things that are covered under the practice of veterinary medicine.
Bill?
I would completely agree with Dr. Pascoe's comments. We recently had a student out of the Midwest that were doing a clinical skills their second year, and we were able to provide, clinical skills training, catheter injections, those types of things, which would then also be covered by this. So one of the things that I had in this, not to wordsmith this at this point, but I just crossed third and fourth out and just started with students.
Yeah.
In other words, students in the program need to be able to do this. And I think my bet, I don't really know, but I would bet that a lot of schools are going to be looking at some of these things being outsourced to independent sites through the years. Clinical skills being one of them, and providing a checklist or an MOU of what these students need to get, and who knows what year it is.
We've got a couple other pieces to this puzzle. So part of it is, do we move forward with this language in some way, or form a task force? There's three things here. The second is the discussion that was referenced in Mr. Hepler's monograph here about decoupling this from exemptions and actually turning it over in the statute, and it would probably end up being some new language in 2027, which is graduates and students of veterinary colleges job passes, and so it would move into a different section and not be an exemption. And then the third thing is the existing language of 2027, what we were talking about in terms of if you're a graduate, DVM graduate, maybe you don't have your DVM degree, and this would appear to allow you to function as an RVT in terms of tasks forever. So we've got 3 different things here, just don't want to lose sight of that. So first thing is dealing with this language. It would be helpful to have a little bit of a discussion about this language as whatever task force we're going to do or move forward with takes that. Where are we as a group with this language, and does it accomplish the goals that we're interested in terms of giving students the exemptions or the ability to do what they need to do with the appropriate levels of supervision, or do we see that this needs to be modified in some way?
A little bit of confusion. I think 4830A5 is statute, so we're going to have to address it one way or another. I don't see, I guess I'm looking at it too simplistic, but I don't see a reason to change the whole format. I think we should stick with that statute, write it the way we want it, want to and not worry about whether we're, decoupling this or whatever. I'm not quite understanding that part of it. So I like what we're saying. I think it needs some work, but I don't see any problem with it being an exemption unless legal can give me a good reason why it needs to be cleaned up some other way.
Oh,
Yeah.
I'm sorry, Dr. Sullivan, I didn't know you wanted me to respond directly. So there is, the only decoupling thing is simply that you have a section of exemptions from licensure. And if you take what's like in the second paragraph, I'm not sure that's really an exception from licensure issue. That's more like when you're going educational training, here's what you expect. So that's why I'm saying I'm not quite sure it fits in the exemption. So that's what's concerning me. I think it's kind of a no harm, no foul, but I believe as a lawyer, you try to bring some elegance to the profession, you try to bring some elegance to statute. So that was my thought. The second thing is probably, as you can see on the left-hand side, page 2 of my memo, there's a whole analog to the human world, and I was just thinking that again, third and fourth students, to me, that's not really an exemption from licensure, it's more of an authorization of what they can do. So you're essentially saying, if you're enrolled in this, whatever the words are, then you, by dint of the statute, are authorized to do this. And I'm not so sure it's an exemption from licensure. So that's one place, but decoupling is not necessary. It's not a fatal flaw. It's just kind of on the bucket list for me. So again, the committee need not render an opinion on that. If I can just take a moment to note, I do believe that Dean Pasco is certainly correct in that perhaps some sponge-like opportunity to suck up what the current status of the education and the profession would serve this language well.
Ellen and then Dave.
So if I understood your question or your point a few minutes ago, as I interpreted it as a question about what direction we want to go. And it seems to me the simplest way to provide that direction would be for a small group, a task force, if you will, that includes the university or universities, that includes one or two of us, legal counsel, and all the documents that we have collated to date, and hammer this out by the next meeting. It seems a reasonable thing to be able to do, and allow every one of the major stakeholders here to formulate that response.
Is there a second to that motion?
Second.
Yes, I have a discussion item. I agree with the idea of a task force, but what I would like to accomplish today with this committee is to throw out some issues, specific issues that the task force should consider.
Okay. So, are you comfortable with us moving forward at this point with the vote on this? And then
Yes.
we can get your list? Okay, public.
So the motion would be to recommend to the full board that we can convene a task force to study this issue, a task force comprising of various educational institutions, some members of this board, the board, and perhaps a member or two of this committee. Is that kind of what the motion is?
Yeah.
That's exactly what it was, yes.
Perfect.
Thank you.
Well stated, I might add.
This doesn't need to go back to the full board, that's just within the internal workings of this group, right? Right.
I duly apologize. I was understanding that you were contemplating making a recommendation to the full board.
No,
Just,
come out of this committee,
yeah.
to then report back at the next meeting with then a recommendation to the board.
It's no different than our subcommittees, except
Right.
for this subcommittee involves outside it's more like research of the MDC to formulate a recommendation before the board. So it's not out of line in terms of protocol.
Any other questions, comments from the committee? Comments, questions from the audience? Okay, can we? Anne Marie, can we call?
Dr. Klingborg.
Here, or I mean.
Dr. Druces.
Whatever I am.
Aye.
Dr. Grant.
Aye.
Dr. Pollard.
Aye.
Dave Johnson.
Aye.
Christy Pulowski.
Aye.
Diana Woodward Hagel.
Aye.
Jennifer Laredo.
Aye.
And Dr. Sullivan.
Aye.
Okay. We'll convene that group and get to work.
And I have comment of one of the issues that I would like
Yes.
to have the task force consider, and that is one that was raised at the last meeting, not by me, by the way. And that is to consider whether the statute, the exemption, whatever, will be limited to California students. And not just students broadly stated of AVMA accredited institutions. That would mean 2 schools.
Okay. Helen?
So I would have a question in regard to that. So there are accredited veterinary faculties within this country, Canada, and abroad. So are you suggesting that any student in an AVMA accredited institution fall under this guidance, or are you suggesting that any student from any university faculty on the planet be included?
Are you asking me?
Yes.
I want the task force to consider that issue. It was raised at the last meeting.
I probably raised it, yes.
So you're asking me to clarify?
Yes, I am.
Right.
I don't want the full blame for all of this.
I'm not even suggesting a direction to it. My concern when it was raised at the last meeting was simply enforcement and verification.
No, I agree 100%. Although the roles are dwindling, foreign graduates are coming to this country in the tune of about 300 a year, some of whom have exceptional skills and some of whom have very few skills. And it certainly is something I think that needs to be discussed, even if we may not be able to reach a conclusion.
Exactly. And the board has jurisdiction over the veterinarian who is accepting the student. But if the student is from a foreign jurisdiction, not meaning a foreign country jurisdiction, but something non-California, and they're gone, the institution is out of state, there's no jurisdiction over out-of-state institutions, you have a problem, and there should be disclosure to the accepting veterinarian that this might be a possibility, even though remote.
Did you have anything else on your list?
No.
Okay, great. Questions, comments, yes? Okay. No? Okay. Yes, Nancy?
In response to Mr. Hepler's concerns about the students not being examined or licensed or have background checks in any way, at the last meeting I suggested that you might want to consider, and put this on the list, to allow veterinary students at some point to be eligible to sit for the RVT exam, which would solve the problem of a graduate of veterinary school performing as an RVT for the rest of their life without actually being licensed as an RVT. And my other suggestion would be to discuss requiring a veterinary assistant controlled substance permit for anybody any veterinary student who is handling controlled substances in a private veterinary hospital setting, since they are not currently fingerprinted or background checked, and that's the reason we have a veterinary assistant controlled substance permit for veterinary assistants. in order to protect the public.
Other public comments? Right, so motion, go ahead.
Part of the MDC's discussion that's included in Kurt's memo before the MDC was the issue of 2027 and how that either does or does not fit within this current exemption. And I think if you're not going to include it in the discussion, then you need to say we're going to tackle that issue separate and apart from this exemption of how we're going to redefine 4830, whether it's an exemption or not. But if you are folding in 2027 into that discussion, that needs to be part of the working group's consideration. Again, right now, we do have, it's very nebulous as to what 2027 does. Does it really allow for veterinary students in their freshman and sophomore year to do things equivalent to an unregistered assistant? And Nancy brought up a point about, are they administering or obtaining controlled substances? So it really does need to be clarified what was the intent of 2027. And at this point, you could have a student that's a graduate who is operating as an RVT without a license indefinitely. So there are some opportunities within 2027 that we need to address for clarity purposes alone, but also to address some of the other concerns that have been raised before the MDC.
Yes, Dick.
Yeah, I would agree with that because I have heard of DVMs that have graduated that don't have a license that are working long-term as RVTs. And if there is a problem, the only way we can go after them is as unlicensed activity. And I think I like the idea that veterinary students can get proficient at RV tasks, but I think it has to be tightened up. And either upon graduation they have to get an RVT license or within the next number of months or whatever. But I think this the task force should look at that and should look at that as a loophole that needs to be corrected.
Yes.
I believe at the last meeting, Dave Johnson had a comment about that.
You did, and it was a brilliant one.
It was, very good. Thank you. Yeah, we all remember it. Yes, Alan.
So I believe I stated in the motion that this ad hoc committee utilize all of the documents that have been prepared for us today, and mention certainly is prominent in here of 2027, so I expect that that would be engaged in this process.
Yes, David.
I do have one question for Anne Marie. On this section 2027, have we gone back and looked at the historical documents? Because it's been amended 1, 2, 3, 4 times that I see here.
No, but that's something that we can
And we
do
might
is
take
in
a look
terms
at
of
that to
research,
figure
because
what
to
has
look
been
at the
changed.
intent.
Yeah, what was the intent each time,
Right.
what we were trying to
Right.
accomplish?
Because I think the intent has evolved.
It really has, from
Yeah.
what we originally did in 77, the last, it looks like 96 was the last time anything was done on it.
So we can pull the rulemaking record.
Okay.
Sometimes that provides insight, sometimes,
May just be more confusing, like what was it?
sometimes you're just left to guess.
Okay,
But we can pull it and see what we can find.
thank you.
So when we voted, we actually were referencing this document with 4838.5. So we have not, when you said all encompassing, I will tell you my understanding of the motion was that all the documents as they reference 4838.5. 2027 is separate. So now I did hear what sounded like a motion to have the same ad hoc group do their due diligence and
So
work on
moved.
Second.
2027. Okay. Okay, any other discussion? Audience? Okay,
Dr. Klingberg,
still here, and I.
Dr. Druces,
Aye.
Dr. Grant,
Yes.
Dr. Pollard,
Aye.
Dave Johnson, Christy Pulowski,
Aye.
Diana Woodward Hagel,
Aye.
Jennifer Laredo,
Aye.
and Dr. Sullivan.
Aye. Great, so motion carries, and I think that takes care of, for the time being,
No,
the chair will appoint, yes.
I still have another item on this.
Oh, I'm sorry, yes.
Out there in left field is something that is been holding that I would like to clear up, and since it's on this agenda item and we have university people here, I'd like to bring it up. And that has to do with premise permits for university facilities that are providing services to the public. I don't know of any exemption in the law about exempting the university clinics from having a premise permit, and now that they're licensed, I think it would be a good point to clarify or to discuss and hopefully clarify the need for having a premise permit at the university facilities, whether it's in San Diego or Davis or
Pomona.
yeah, would be Tulare would be another one. So I'd like to discuss that and see where we're at with that issue.
Well, can I respond?
Yes, please.
It's loosely connected to the exemption, so that's where that connection's made. The exemption in 4830 exempted UC Davis and Western School, or in Western College of Veterinary Medicine, from oversight of the board. And this other exemption, as it exists, is about students. The exemption with regard to the university is being, I don't want to say rectified, but changed in 1193, which would remove the universities from being exempt, thereby remove their facilities from an exemption as well. And that's a conversation we've had with the university, and if Dr. Pascoe would like to address that, you'd probably clarify that the student exemption, because students are working in those university facilities, the students would remain students, and whether you want to call it an exemption or as Kirk described it, this is what to expect if you're being trained from one of the colleges. That in and of itself is one issue. Where they practice and the board's oversight role is a separate issue, but it is being addressed in the university licensure piece that universities would have to have premises permits for those clinic settings. Dr. Pascoe, do you have anything to add?
Only to concur.
Okay.
So we have had discussions about that, at least Anne Marie and I have, that once the university licensing went into effect, then the premises license would sort of follow suit. I don't know the historical reason for the exemption, to be quite honest. We don't have an objection to it, so.
Okay. Thank you.
Okay. So that concludes that agenda item. We're going to take a 10-minute break and then get into compounding, and it's 10 minutes, people. 10. On agenda item number 10, which I'll summarize the long agenda item as the discussion of compounding medications in veterinary practice.
Oh my goodness, you're gonna punt this one to me. Okay, so we are all aware that Senate Bill 1193 includes an authority for veterinarians and RVTs under drug supervision to compound drugs for animal use pursuant to federal rule. Federal rule is fairly limited as to when a veterinarian may compound drugs for the care and treatment of the animal. In the packets today, what we've attempted to do is to provide you a great deal of background that's going to be awfully confusing, but a lot of information that we need to consider before we craft regulations. First and foremost is relying on the boundaries of federal rule, which are fairly restrictive. The federal rule I'm referring to is the Title 21, Part 530. There's also a federal guidance document, and that guidance document deals with bulk compounding. And there's probably some confusion on everybody's part when we talk about FDA-approved drugs and those drugs being mixed or compounded versus bulk compounding. So the guidance document that's clearly a guidance and not a law or regulation is actually a draft guidance. So it really does kind of hamstring what we're trying to do moving forward when we start talking about bulk substances, because that's not even a formal document for the federal government yet. But it does provide some insight into the direction that the federal government is going. So I want to make sure that we keep in our minds that there is a separate rule, if you will, for compounding of FDA-approved drugs versus bulk compounding. Oh, sorry, Kurt, I thought you were going to move forward. So that FDA guidance document, number 230, is in the packets. It's just a summary that actually the AVMA kind of condensed the very long and dry document into something that you can digest. Also, pharmacy regs. So right now, there are regulations pending before the Board of Pharmacy that are currently with the Office of Administrative Law that deal with compounding by licensed pharmacists. They also include compounding by veterinarians in terms of what a pharmacy can supply a veterinarian, the length of time they can provide a compounded drug for purposes of in-office use and also dispensing to their clients. It's important, though, that we look at the regulations of the pharmacy board when we formulate the regulations for veterinarians, because they're very specific guidelines to how to compound drugs, especially that being sterile injectables. There's different types of sterile injectables that we're going to talk about today. Immediate use versus something that's beyond that 1 hour preservation time period. With the pharmacy regulations, you have UPC 797, which really outlines the extensive equipment and protocols that have to be followed if you are compounding drugs and you're doing so for the purposes of creating a product to sell to the public. So that's another layer of discussion. Are veterinary practices capable of really complying with UPC 797? Extremely extensive. The equipment is nothing short of, it's your own manufacturing facility within your veterinary practice. And then on to the next attachment, which actually is the legislation 1193. And it's important to note in the legislation that it's not just the authority that's outlined. It also gives some instructions to the board that we are to promulgate regulations at a minimum that addresses the storage of the drugs, the level and type of supervision required for compounding drugs by an RVT, and the equipment necessary for the safe compounding of drugs. The regulations should be adopted in consultation with the Board of Pharmacy, because that was the discussion that we had in this statutory amendment, that we would be consulting with the Board of Pharmacy on our regulations as we go through developing them. I think today what we need to do is look at a draft document that was originally formulated by Supervising Deputy Attorney General Josh Room. It's in your packets. There's been some changes to that document. Those changes reflect comments that we've received from UC Davis, from CVMA, and perhaps there was some work with Western, but I'm not sure about whether or not Western was involved in terms of commenting on the regulatory text, the draft regulatory text. I will point out some things in this regulatory document that we're going to have to remove, and that is any reference to authority over pharmacists, pharmacy technicians, intern pharmacists. This board has no authority to regulate the functions of another healthcare practitioner that is not attempting to practice veterinary medicine. So that will not be part of our document. Another area in this document that clearly reflects definitions that are from the Board of Pharmacy, which is not necessarily a bad thing, but we do need to reference contextually where this came from, and that is how we define compounding. This definition is not something that we're creating separate and apart from that already exists. This is something that we're borrowing from California Code of Regulations 1735. It's not to say that we can't restate it in our regulations, and in fact it might be a very good idea so that we're not asking veterinary professionals to resource several different code sections to understand the scope of drug compounding. And then also in your packet are the actual comments submitted to Dr. Klingborg from UC Davis, and there was a group there that worked on looking at the draft language, and also comments submitted from CVMA in terms of their concerns, which were really more concerns that were addressing the statutory structure before it was really kind of reduced down to just being an authority according to federal rule. So I think we've addressed some of those concerns in how we changed the statute. However, moving forward with regulations, this information is going to be helpful in how we define and draft the oversight.
Done at this point. So we do have some proposed language here, but it's still not at all ready for prime time. I mean, there's a lot of bits and pieces, and really what I think we need to be doing at this point is still collecting some information before we sit here and try and write the regs. The regs will be written in a subcommittee and then presented, and then we'll rewrite them as a group, not just yet. But I would like to hear, unless there are specific questions from this group, the committee, I'd like to actually hear from audience members. We've got some folks deeply involved with this at UC Davis that can help provide us with some insight among others. So are we comfortable at this point learning more? Good, okay. Dean Pasco, would you like to, you've got folks in the audience, I think, that might have some input or like to give us a frame of reference that could help us.
We'll maybe answer questions.
Okay. Well, we'll need you up here to answer questions as we make them up. Yeah. Yeah.
Like it or not, you gotta move.
Hi, I'm Jenna Burton. I'm a medical oncologist at UC Davis.
Hi, I'm Gary Magdesian. I'm an equine internist and also board certified with American College of Veterinary Clinical Pharmacology. I'm also on the AVMA task force for compounding from bulk drug.
So we're keenly aware of the importance for the profession to be able to compound medications and numerous examples, and we're, again, very familiar with that. My question is, how do you compound in your practice life? What is that process? Who does it? What is the facility like to do that? And help us as we try and understand and live within the regs that are in front of us and do this in a private practice setting or in all the various facets of the profession.
I'll start. So the university pharmacy does very little compounding there. As an oncologist, working with drugs that have a very narrow therapeutic index, so too much drug and you have severe side effects, too little drug, you don't treat the cancer, it's really important that we are able to appropriately dose our patients, especially those smaller ones, so small cats and dogs. There are 2 FDA-approved cancer drugs, one fully approved and one on conditional license. So everything that we use is off-label. They're FDA products. So I really rely on compounding pharmacies, working with the large public compounding pharmacies when I need to compound drugs for my patients. Compounding is really an important issue for us. I have grave concern about the quality of some of the product that we get from these compounding pharmacies, which is well beyond the scope, but and we've done some research at UC Davis indicating that it's not uncommon that often the potency of the drugs that we get are not what we're prescribing to our patients. So while it's essential in my practice, I'm also very reluctant to do it unless, I'm in a situation, and then I feel like, based on our research, I always have to educate our owners that I have to do this, but there is a chance based on some research that we're actually not getting the amount of drug that we think we're getting in this product, so.
Can you ask me that question one more time?
Tell us about how you use compounding.
How we use
in your
compounding.
practice life.
From an academic standpoint, our pharmacy, as Jenna said, is considered a drug room, I think is what it's considered, not a pharmacy. So they don't do compounding in general. So again, we rely on compounding pharmacies for the most part. Other than on a day-to-day basis, what we rely in terms of the pure definition of compounding is a lot of immediate use, mixing of anesthetic drugs, sedatives, intra-articular medications, fluid therapy, TPN, that kind of thing is done routinely by the veterinarians. I think in practice, serving on the task force and being in a great group of diverse backgrounds, I think it varies quite a bit with species, and I'm probably not the best person to speak to this, but for example, the feline practitioner on the committee would point out a lot of times where they were having to compound because of size issues. The veterinarian representing exotics and wildlife, that's a whole nother sort of area of where compounding is very critical because they have no FDA-approved medications for those species. So it's wide-ranging. I think the answer to your question is very wide open in terms of the varying sectors of practice. But I think maybe two sort of categories. One is that immediate use of compounding that's done by probably every practicing veterinarian who sedates, anesthetizes, administered IV fluids and TPN versus the longer-term prescribing of medications and preparations.
Dr. Burton, is the concern about potency that you described, do you think that's specific to oncological products, or is it more general in other small or even large animal use?
I think it's a general concern. There's been some dermatologic publications and internal medicine looking at things like cyclosporin. So I think it's potentially widespread and not limited to oncology.
It's widespread, I agree. Colleagues there at UC Davis have looked at omeprazole, for example, for horses and shown that compound preparations are ineffective. Scott Stanley's looked at a number of antimicrobials like amikacin, for example, and shown that the potency is outside the recommended range with something that, again, has a narrow therapeutic index. So I think it applies to all compounded preparations.
So are you both suggesting that there's flagrant fraud in the compounding pharmacy business?
I don't personally.
Or are these mistakes?
As an oncologist, I'm an optimist by nature, so I have to believe that it's not ill will. My gut feeling is that perhaps some of this becomes more of an issue when they're working with bulk substances, but that's just a guess on my part.
They're not FDA approved, so they're not subject to those rigors. I think they're just not as well regulated as they could be.
Compounding is a necessary evil. That's how I've come to view it in our profession.
And with being on the AVMA task force, can you give us an update on where the federal government is in their regulations on veterinary compounding?
Yeah, the task force has completed our document, so we recommended some legislative language and for federal oversight of compounding from bulk. This task force was specifically for bulk compounding. And so we've completed that, and the board has, I'm told, has looked through it and has looked upon it favorably, and now the lawyers are sort of looking through the language. So that's where it is.
And then that will be forwarded to federal officials?
Yes. I think they'll probably solicit ally input again, and then that's the goal ultimately.
The variability of potency, effectiveness, have you found differences between different sources? You know, I think most people here, I think all people are here working on small animals, so I don't have a large animal example, but I find myself in small animal compound prescriptions dealing ideally with just 3 or 4 places, and they typically, I'm sure you're familiar with them, overnight them, but I don't have any basis for, and I don't know what the letters behind their hospital, their pharmacy names mean, because there are multiple certifications, and at least it's not commonly known in our world, I don't think. So the question is, do you find differences between Wedgwood and Roadrunner and down the street ABC?
The answer is yes. So we published a study earlier this year with Scott Stanley, and what we did is we got the same drug at the same strength from 5 different compounding pharmacies, and I was blinded to all the pharmacies that the results. I honestly don't want to know, because I don't want to condemn or praise a pharmacy based on one sample at one time, but what we found that the potency ranged in those 5 samples from 50% to 115%, with only one sample falling within plus or minus 10% of the labeled concentration. So,
How variable is it, do you think, between lots in the same pharmacy?
exactly. I mean, I think we don't fully know how variable it is. I think we're just kind of scratching the surface on this, and I think we just don't know.
That's scary stuff.
What
Yeah.
was the active ingredient of that drug?
Lomustine, or CCNU, as it's also known.
Reading the documents that we're seeing that are going through regulation now on the human side, I thought that part of compounding required verification of efficacy. I thought that's part of what is there. Is it not being done, or is it not in the regulations yet?
I don't know if Gary can speak to that better.
Efficacy, no, that's on the onus of the prescribing veterinarian, actually. And in my understanding is in some of the court cases where there have been fatalities, like with horses that received compounding preparations, the onus on efficacy was on the prescribing veterinarian rather than the pharmacy.
Well, I shouldn't use the word efficacy, I should use
Potency, yeah, potency. That's a good question. I don't know what specific regulations compounding pharmacies operate under. My understanding is that certain lots are they're supposed to have certain lots tested, but I'm not sure if it's every lot or not.
Other questions?
So I just want to raise a couple of hurdles that we're going to have to speak to when we go through this process, and maybe AVMA has already, I'm sure they're aware of them, but if you look at the actual extra label drug use in animals, which is that section 530, it talks about nothing in this part shall be construed as permitting compounding from bulk drugs. So right now there's a little bit of a disconnect where it says federal government saying veterinarians you can't compound from bulk drugs, period. That's why you're going to a compounding pharmacy and you're having these things done out, you're outsourcing it. But then we have the guidance document that will provide for some, if it ever sees the light of day in terms of a formal document, and whether or not the guidance document in and of itself can serve as the basis for this group to address bulk compounding is something that council is going to have to look at. The guidance document talks about bulk ingredients that are used to prepare a compound that contains the same active ingredient as in an FDA-approved animal or human drug. And if you are compounding from a bulk substance that contains an active ingredient from an FDA-approved drug, it has to be for a specific individual patient, and it can't be bulk compounding for, a population, if you will. So there are some limitations still within the guidance document that we're going to have to necessarily speak to in the regulations here in California. And I don't know if those details have been discussed at the AVMA level, or whether you're really focusing on when a veterinarian has to compound from bulk substances and what level of compounding, and I don't know if you have a percentage, but it would be helpful for us to know how important is it in terms of availability and access for a veterinarian to use bulk substances for the purposes of compounding. What percentage of time is that absolutely necessary? And do you foresee these outsourcing facilities that are supposed to come online now for animal drugs taking that need from the private veterinarian and just your comments.
Yeah, I would say from the task force point of view, the need for compounding from bulk is critical, particularly for certain aspects like wildlife exotic, where the percentage of preparations used is from bulk compounding is very high, very high. So it would vary, I would say, with the specific veterinary sector in terms of the percentage of preparations that are compounded from bulk. But the consensus was that it's critical that it be allowed for veterinary practice. I don't know if that answers your question.
I'm really looking at this committee having the justification for moving forward beyond what's currently maybe authorized in federal rule. Because we are limited by, and it's something that's called, we can't, what is the word that we can't go beyond federal rule? Yes, we can't preempt federal rule, it's escaping me. So we really have to look at, okay, today it may be a preemption of federal rule, but we already have the federal government working on a guidance document that would permit this bulk compounding. And there is a need in the state of California for this to occur for these reasons. So we really need sound justification as to why this bulk compounding is so important, and to the degree that we can't get this compounded product from either a compounding pharmacy or an outsourcing facility, we're going to have to document and justify that. And perhaps I've seen the AVMA comments. I don't know whether they went into that sort of detail. I can't recall in terms of the percentage of time a veterinarian would be unable to get these compounded products, bulk products, from a compounding pharmacy or an outsourcing facility.
We didn't go into that specifically in terms of when a veterinarian would not be able to access those.
Or what's available.
Or what's available.
That's going to be a very important component to justifying the need to compound from bulk substances.
I think the drug shortages, at least from a oncologic perspective, it's happened in the human world. You just can't get effective drugs, and so that's what led to us compounding this drug CCNU. You just couldn't buy the FDA formula, and you need it to treat your patients. And so I think for me, the drug shortages and then the small patient size, that those little cats, those little dogs, I mean, those are the main reasons that we turn to that, at least for me.
Outsourcing, you had, I think, a question about outsourcing facilities, and the task force has huge concerns over that part of Guidance 230 document because of the concern over access and whether current outsourcing facilities would be willing to produce veterinary drugs, and whether any of the existing compounding pharmacies would go to the lengths of becoming registered as outsourcing facilities because they have to, I think they have to produce at least one sterile human drug, and it adds a whole layer of complexity in terms of regulations and then expense as well for the veterinary pharmacies, so that we had a big concern over that part of the guidance document and communicated that.
It seemed to me in reading the guidance document that there was this maybe push or opportunity for there to be actual outsourcing facilities that were specifically, if you will, they start up for just the purposes of animal medicine. And I know that currently doesn't exist, and that was one of the issues that was raised by AVMA, is we don't have outsourcing facilities that specialize in animal medicine. I'm not familiar with the requirement that you're talking about, that they'd have to produce a human sterile injectable, but that is something that I can ask the Pharmacy Board in California. I don't know if that's a federal requirement, maybe that hasn't.
Currently, I think it is
Okay.
part of the federal requirement that outsourcing facilities produce at least one sterile compound. And so we were concerned that's really going to severely limit the number of facilities that produce veterinary preparations to maybe one or two of the largest veterinary compounding pharmacies that currently exist, because it's going to be so expensive for them to do so.
Right. Thank you. It's good
Yeah.
information.
So one of the most common types of compounding is mixing ketamine and Valium and using it for induction. And yet it would fall outside the scope of this if we're not using the whole bottle within an hour.
Mhm.
So where's AVMA on that? Do you have a sense as to whether or not they're having that conversation with the federal government at this point?
That I can't answer per se because that wasn't part of our task, but that, I mean, I share that concern of.
I mean, we're trying to craft language to fit within USP 797 and everything else.
Mhm.
But it's, you know, we want to live within the letter of the law, but we also need to service the population, obviously.
That's right.
Yeah.
Yeah, that sort of sterile compounding can't feasibly fall under 797, you know, when you're talking about sedation, anesthesia, fluids, that sort of thing.
Other questions? Yep. Oh, yep.
Were you two involved in writing this or presenting this that we got in our packets? Do you know?
No.
No.
They weren't.
Okay, thank you.
No.
Then I won't ask them a question.
Yeah.
Thank you.
That language that's in your packet, it's something that I distilled based on input from UC Davis and from CVMA. So the two letters that follow that, I took Joshua Room, who started this ball rolling, and he doesn't deserve to have his name on it anymore because it changed it substantially. But this was a beginning of that conversation.
So the letter that starts with Dear Dr. Klingborg, though, that came from UC Davis?
That came from UC Davis. That came from.
That was, I think, from Valerie Wiebe, our pharmacist.
That's correct.
I just noticed that there's some things that were in that still have not been addressed in the new language, that still are not clearly addressed in that I think are important to be addressed.
It's daunting, and also, again, we're talking about being preemptive, and so it's a challenge of trying to do that dance.
Well, and I also noticed, so I was confused, so I'm glad you clarified it, because it says Joshua's Room's name on it, but I noticed your initials in an edit, so I was kind of confused on that.
He gets no blame at this point, and I get all of the blame. But
So.
Again, it's very tricky, and then the other thing is USP 797, which is what regulates sterile compounding. You got a couple of handouts today on that. Well, there's low risk, medium risk, and high risk, and which risk group that's in isn't necessarily based on the drug. It's based on how many drugs and how quickly it's used. So the same drug, if it's going to be used sometime later, becomes a medium or a high risk versus a low risk. And so it's an immensely complicated conversation.
Well, it also depends on how much compounding you do and what kind of compounding you do. So I think there's categories and there's subcategories and subcategories.
So we wanted the experts here today to try and help us sort that out, and I appreciate your input. Anything else you want to add as we try and tread forward?
No?
I think so.
Thanks for the opportunity.
Thank you.
Okay, thank you very much. Okay, other public comment on compounding?
Okay, not to be Debbie Downer, but this is quite a daunting task. Number one, you see federal involvement, and federal agencies are big on guidance documents. The state of California does not really recognize guidance documents, and quite the opposite. We have a piece of statute in the APA that talks about you can't enforce guidance or manuals or bulletins or good thoughts or good ideas unless they're adopted via regulation or statute. So we have that tension. Number two, in my small world, I'm going to borrow something from my colleague here. I'm going to go back to circles. So here's the world of compounding. Looks like a University of Oregon symbol, but there's the world of compounding. And then a little bit is veterinary compounding. So I think we have to remember the size and scale as we go forward, because compounding has usually been, until recently, reserved for pharmacies and pharmacists. So we're getting a little cutout of compounding, and that's something that we have to distinguish and dissect as well. And also, our enabling statute is somewhat helpful because it's very broad, in that it says you're gonna do this, you're gonna consider those things, so that's good. And it's somewhat impeding because, as the executive officer pointed out, we're gonna have to show our work. Because one of the things that, as we develop the regulatory scheme or the regulatory structure, is gonna be, we're gonna have to, in our initial statement of reasons, we're gonna have to show our work about why we chose this, why we chose bulk compounding, why we said it's not an hour, it's 59 minutes, and we are gonna use the whole bottle, or whatever, because we're saving for a party for Friday night, or whatever. Okay, so all that kind of stuff, so that is a daunting task. It can be done, just gonna require a lot of input. I anticipate, while we could have the better part of quite a voluminous tome here when we get done this regulatory process. So I'm just letting the members know, remember, the purpose of regulation is to interpret, make specific, or implement statute. We're gonna have volume 1, side 1, side 2, side 3 when we get this done.
Yes, Dave.
Yeah, I've read their proposed regulations several times, and I do have a conflict that there are some situations that we can't fit in, and we may have to approach it with an exemption. Because it's critical from a standpoint of being able to dilute some of these medications adequately in a vehicle that we can then use safely. And we can't do it every 1 hour. I mean, it just would be so expensive that we would be out of business. So I think we're going to have to approach some of this from that angle.
Other comments? Public comments on compounding? All right, we will move on to our next agenda item. Agenda item 11, public comments on items not on the agenda. Seeing none, hearing none, we will move to agenda item 12, our next meeting dates, proposed meeting dates. Where's our October meeting, I guess, would be one question.
So our October meeting is going to be in Southern California somewhere. I think, Ethan, if I'm not mistaken, are we looking at Orange County? Okay, we're looking at Orange County because that's where we seem to have luck with hotels that can webcast and will accommodate our, great food, fantastic food, wine cellars, all that good stuff, because that's important when you're doing the government's work. But that's where we're looking, so hopefully we'll be in Orange County in October. Future meeting dates, for the purposes of the MDC members, we gave you an agenda that had a wrong start time, but it did have future meeting dates on it, so we accomplished one thing while we screwed up another. But proposed meeting dates, January 17th, 2017, April 18th, 2017, July 18th, and October 17th. So that would be the proposed calendar for 2017, unless there's any objections to those dates or we have conflicts.
Could you repeat that?
I'm sorry, it's January 17, April 18, July 18, and October 17. And location TBD, so it just depends on what we can, we'll see you here.
Okay, any questions on that? Agenda item number 13, our 12A, our assignment priorities. So we've got existing priorities, evaluate structure and audit enforcement case outcomes. Item 2 is develop minimum standards for alternate premises. Still working with the CVMA premise task force on that. We've also got our shelter subcommittee as part of that. Item 3, review 4830A5 veterinary student exemption, and also 2027 is on there. And as we know, we're going to form a working group with the veterinary schools in the state on that. Item number 4, we're going to maintain on the agenda for next time, pursue extended duty for, and I'd rather it say discuss rather than pursue, for registered veterinary technicians. Item number 5 refers to developing these regs for compounding. Try and get that done before I term out in 2 years. I mean, this is going to be insane. Item number 6, just keep reforming the darn task force. That's how you've done it in the past. Is rodeos. Item number 7, what was develop minimum standards for spay and neuter clinics. This came out of the BMB meeting last time. So that's where we are at this stage of the game. Anything to add to that? Yes, Beth?
One thing that, maybe, Mr. Chair, you can discuss with BMB, I'm assuming you're gonna talk to them about the priorities. There's been issue that's come up where we have mobile specialists, be it surgeons, internists, doing procedures at hospitals, and the question is where does their responsibility for case management begin and end? I am aware of several cases where there's been a discrepancy between, well, you know, the veterinary technician is providing anesthesia from the hospital, but the mobile surgeon is there doing the surgery, and there's an issue comes up, you know, who's in charge? And this has become something certainly pretty prevalent in the Southern California and probably the San Francisco area. I actually just spoke to somebody yesterday about this from San Francisco and who's responsible. So maybe mobile specialty procedures can be an issue that you bring up with them if the VMB feels good, sending that back to us, and then we can set it up in your lineup.
And the other addition that I see is discussing just a standing RVT issues. Yeah, we've got the extended duty, but we talked about maybe just having a line item that's kind of standing RVT issues. We've got an agendized place where we can have that discussion. Any comments on our priorities?
Clarification.
Yes.
The sedation versus anesthesia issue, were we gonna add that?
Yeah, I wasn't sure if how that melded into our shelter conversation.
Shelter discussion, we're gonna bring that back during that discussion.
Okay.
Be prepared to discuss.
Okay, so you want to include it under shelter medicine, not as a general minimum standard topic?
We'll talk about it as a separate, we'll ask if we may talk about it as a
There you
separate.
go.
Yeah.
I think it needs to be a separate.
Yes, yes.
Yeah.
Good. Yes. Oh, yes, Dick.
Just a comment, I do not like standing issues.
Okay.
I think that if there's an issue that comes up, I think that we need the material and the data ahead of time so we can look at it. A standing issue really opens up the avenue for discussion that the board may not have background material on, and I think if it warrants on the agenda, it should be specific so we can have material and data.
I don't disagree, and I don't think that's what I was asking for either.
Okay.
I don't know about Dave, but I think our goal and our objective was that as a standing issue, meaning every item that is presented to us is an RVT item. So whether it be, you know, when we look at audit enforcement, how does an RVT fit in that? When we talk about minimum standards, how does an RVT fit in that? When we talk about, you know, reviewing business and profession code, how does an RVT sit in that? I mean, that is what we mean when we talk about RVT issues. And correct me if I'm wrong, but that's what we were talking about. And we need to be diligent in our role on the committee that it is not a standing issue and say, are there any RVT issues? Because we could be here all day. And it is a matter of, we are talking about a profession. And that means, as a profession, bringing up veterinary and RVT issues together, not just singling anybody out, because we are together in this.
just because council's gonna have heartburn if we don't say something. You can't have an issue that's just you can't have an item that's a standing issue without a description of what the issue is on the agenda. You can have standing reports, but when you have standing reports, you're not discussing the issue in terms of taking action. You're giving a report about issues that have come before you. So I think we would have an agenda problem even if we tried to do that. And I think you will get RVT issues out of just the discussion alone from the issues you have on the agenda, and also from the report before the VMB, which will bring those items before the public so they can be agendized in the future.
And just to expand a little bit on what Dr. Grant brought up, and number 7 on future priorities. It's not limited to fracture repairs that these surgeons would come in and do surgery. It's our shelters where I've got 6 per diem veterinarians that come in and do anywhere from 20 to 50 spays and neuters at one time. They're out the door, and whose responsibility is left?
They want to be out the door.
Correct.
All right, any other discussion on the agenda items here?
Just one final question on the audit task force, the evaluate structure and audit enforcement case outcomes. I know we're leaving it on here because we're still going to continue to have our subcommittee audit cases. Is this with the expectation that there will always be an agenda item for it? Because I don't think between now and July we'll have any further recommendations at this point. Is that your feeling?
Between now and October.
Now in October, when I figure out what month I'm in, between now and October. So we're not anticipating it will necessarily be on the agenda.
That's correct.
Okay.
Only if there's a report to come forward.
Okay.
And I do question the expert witness subcommittee. Is their work done at this stage?
That's what I was going to.
Okay. So we will sunset that committee. Other questions, clarifications? Okay, it's been a good day's work. Somebody willing to make that motion to adjourn?
Second.
We stand adjourned. Thank you.